I'm Dr. Keith C. Ferdinand for AHA Science News. We're at the AHA 2023 Hypertension Sessions, and I'm going to be speaking to Diana Baptiste, who spoke yesterday. How are you, Diana?
Hi, I'm fine. Thank you, Dr. Ferdinand.
All right, so what did you address?
So yesterday I addressed multi-level causes of inequity in hypertension control. And yesterday I actually focused on racial ethnic minorities and what their hypertension control looks like.
What's the picture? What's going on?
Oh, big picture. So Dr. Ferdinand, we looked at a lot of studies and we looked at a lot of data, but I don't really want to be focused on the data today. I really want to be focused on the concepts around hypertension control. And so what we found is that within the data and in a few studies, we compared hypertension control amongst those who identify as Black or African American, those who are non-white Hispanic, and those who are white persons as well. And we saw stark differences between these racial ethnic groups. And what we found is that specifically persons who identify as Black are definitely not having a good hypertension control right now. And so we wanted to look a little bit deeper and see what were the reasons. So of course, firstly, we always think of social determinants of health. And as we know, social determinants of health entail education, employment, income, socioeconomic background, neighborhood characteristics, right? And so those obviously are always social barriers. But what we also find is that those social barriers don't apply to all Black people. One of the things that kind of bugs me a little bit is that often Black people are preemptively associated with poverty, right? Or these social determinants that really kind of push them back in our society. And that's not true for all Black people. But what I found in looking at the research is that whether you're poor or whether you have a high or low education level, as a Black person, you're still at high risk for not getting the quality of care that is needed to control hypertension.
What is the reason for that? Is the person getting clinician visits? Are they going to the doctor or the nurse practitioner?
Absolutely. So we found that access to care is not an issue, right? So maybe 10, 20 years ago, we were looking at, poor access to care, people aren't going to the doctor. That's no longer the case. People are going into their clinician visits. They have access to care. They have health insurance. One of the problems that we found is that although someone might have access to care, they might be going to their visits often and they're actually keeping up with their follow-ups. There's a gap in there between these follow-ups where the treatment hasn't changed, right? So for example, if someone has hypertension and they are on intensive treatments for hypertension, maybe the medication regimen that is prescribed, through these follow-up visits, we find that there are many missed opportunities to intensify the treatment as the blood pressures are going up. So although a person could be going into their clinician visit and their blood pressure is higher than usual, or maybe just the trends in blood pressure are going up, what we're finding is that clinicians aren't adjusting their medications to meet those needs.
So is that the same as what we call therapeutic inertia? The person goes to the doctor, goes for the visit, and the blood pressure's up, but there's no change in therapy, or the patient doesn't see a change in their whole blood pressure numbers?
Absolutely, right. So there's a missed opportunity for changing the therapy. There's also patient to provider communication gaps as well. And I had a conversation actually recently about how some patients are going to see their physicians and they're not quite always, maybe the education that they're provided about the medications feels a little bit rushed, or sometimes they're adding new medications and patients aren't quite understanding of why they're taking these medications. But again, it really boils down to physician or provider and patient communication, and that we need to reduce those gaps. One of the things that I also found in a lot of the work that I do is that implicit bias plays a huge role, and particularly from the provider side. Again, when you're thinking about working with patients who are racial and ethnic minorities, whether they're Hispanic or Black, there are often preconceived stereotypes about these patients.
So you have to sit down with the patient, culturally appropriate, literacy appropriate level. Don't use all those big Latin words to show how smart you are. Don't stand over the patient and mumble something and expect them then to adhere.
Absolutely. And I think from my experience, one visit doesn't fix the problem, right? So I think, visits can be, although we might even have, let's say we have a half an hour or 1 hour with a patient, That, it sounds like a long time.
15 minutes.
15 minutes. Oh, wow. So I'm being generous here. But, whatever time you have with the patient, it goes by pretty quickly. And you think about the patient on the receiving end, they're receiving a lot of information. And some of this information can be very unfamiliar, and it takes time to process. And so that's why, follow-up is extremely important. It's extremely important to continue these conversations and assess the patient's learning needs. What do they know? What don't they know about their hypertension, or how to control their hypertension?
So if you had one take-home, one big picture that you thought we could do to address these racial and ethnic minority population disparities in hypertension control, there is no one thing. But let's make it two. Give me two. Give me two.
Give me two. Okay, so yes, it is very complex. It is multi-level, and that's what I presented yesterday. And I really wanted to talk about all of those complexities that really, that we need to consider as we're trying to target these disparities. Okay, so two things. Let me think. So one thing that comes to mind for me is cultural safety. Cultural safety is it's not a new term, but fairly new to a lot of clinicians. And really, it's all about just establishing a trusting relationship with your patients, achieving what we call cultural safety. And cultural safety takes you beyond cultural competence, right? It's not about, I know your culture and I know what what your practices are. It's really about listening to your patient. It's really about asking them about what they do on a daily basis and what works for them, and helping them feel safe in that in this space that you have created, and in the discussions that you're having around themselves, around their hypertension, around their whole entire health. And so I think as clinicians, we need to make a concerted effort to truly try to understand what cultural safety is and why it is so important for us to achieve this with our patients, so that we can just help them be successful. Hypertension is hard. Controlling hypertension is hard. We know that, and this is why we do this work. However, beyond just looking at social determinants of health as a barrier, we also really want to ask questions to our patients to understand what other barriers are. And sometimes that barrier comes from us. Sometimes a patient could say, well, I just didn't quite understand this new medication that you're prescribing, or I didn't truly understand why I am on these therapies.
So trusted space, patient feels part of the team, shared decision making.
Yeah, shared decision making, absolutely.
Give me one more. And I'm simplifying because this is a short discussion that we have, and I recognize that part of the discussion that you had is that it's multi-level, and it's not one or two things. Right. So I understand I'm simplifying. So give me one more.
One more. So I'm thinking of something broadly. One of the things I presented yesterday was the health systems level. Our system needs to change. We really need to advocate for policies that are going to protect our patients, policies that are going to give us more time for our patients. Yeah. 15 minutes is not a long time to talk about hypertension, especially if it's a new diagnosis. So really, just broadly, again, multi-level problem, multifaceted interventions are needed. But we, as clinicians, I think on the more intimate level, we really need to think about how to learn how to achieve cultural safety. And on the broader level, really thinking about how our health systems can support us in helping our, just helping us implement these really important interventions that's going to help our patients in the long run.
That 15-minute follow-up is not enough, but sometimes it's mandated by health systems. They actually keep little records of how many patients you may have seen that day. What can you do to augment or add to the time that the patient is in contact with the health provider in order to get more information to power themselves?
Well, thank you. That's a great question. That's a wonderful statement, because my thoughts are health policy. Definitely I'm thinking okay, health policy needs to change, but we know that can't be done overnight. We're always advocating for health policy change, and we're always taking these very small baby steps, which we appreciate these very small victories towards making change, but we know that it can take a long time to change that. So really on the back end, what we can do with our patients is maybe thinking about other ways for follow-up, like telephone follow-up. If you work with a nursing team, you can, or have your nursing team do follow-up phone calls, follow-up patient education, follow-up counseling. Another part is research funding. Maybe we can start thinking about applying for grants that can fund that time with our patients, fund our more follow-up calls, or using mHealth technologies and text messages, WhatsApp groups and things like that. We have so many great technologies that we can use that I think could really help our patients, and many of our patients are dependent on technology for their information, for their health information. So we could use those health information technologies to reach our patients, send them reminders, set up phone calls, even if the phone call is a 5-minute check-in. And again, time is money, and so thinking research funding would be a good way to go, grants, donations, and different ways that we can ethically approach our patients outside of the clinical visits and help them just really understand that we're not just here to treat them and to diagnose them, but we're here to support them.
Partner with the patient.
And partner with them, yeah.
Well, I really appreciate your presentation and your description. I tried to simplify it, but you told me it's complex, it's multi-level, but there's a lot we can do to do better. Yeah. I'm Dr. Ferdinand, speaking with Dr. Baptiste, and we've been discussing multi-level interventions to reduce inequities in hypertension.